respected senior members of our fraternity, ladies and gentlemen, it is indeed a great pleasure to come to God's own country, and I thank the organizing committee, particularly Dr. Jayakrishnan, for giving me this opportunity. And as you have heard, I come from the Eastern India, and I bring greetings from Kolkata. What I'm going to talk to you today is about a very simple topic. It's about medicine, which has revolutionized the infertility treatment. It has made it very safe. It has made it very simple. And I want to share my experiences with you that how the infertility treatment has become very safe and effective in our own practice. And that agent is called GnRH antagonist. And I'm going to talk to you about its role in ovulation induction. GnRH is a decapeptyl hormone. All of you are aware about it. It's released from the hypothalamus, and it's very crucial in controlling gonadal function and giving the normal ovarian activity. It's normally secreted in a pulsatile fashion. Now, GnRH will get itself attached to the gonadotrophic cells and release FSH and LH, and that will lead to maturation of the ovarian follicle and finally ovulation. Now, if we change the structure of the GnRH molecule, then we can get some benefits in our ovulation treatment. So if we change just one, number 6 peptide, then we get GnRH agonist. And if we change several ones, we'll get GnRH antagonist. Now, when GnRH agonists act, they will go and occupy the receptors. So initially, the effect will be like stimulation. So initially, there is more FSH, LH secretion. But subsequently, what we find that this agonist will desensitize the pituitary receptors, and thereby it will start acting as an opposite action, that there will be less release of FSH and LH. So with agonist, initially we get stimulatory effect, and then we get suppressive effect. It is the suppressive effect we are looking for, but we have to bear with the initial stimulatory effect because of this peculiar mechanism of action. But with antagonist, they will occupy the receptor cells immediately and will give us instantaneous antagonistic effect or prevent release of FSH and LH. So in summary, on the left hand side you have the GnRH, where you see pulsatile action. So LH will be released in a pulsatile fashion. In the middle, we have GnRH agonist, where there will be initial stimulation, then suppression. And on the right, we have GnRH antagonist, which is going to suppress immediately. So in summary, we have GnRH agonist, which will downregulate and desensitize. And the whole purpose is to prevent premature LH surge, which is very important, as you have heard from Professor Pratap Kumar, that affects the ovulation and the result. Definitely, it also helps in reducing the risk of ovarian hyperstimulation syndrome, because we'll have many follicles. It has been said that it improves the chance of ovulation, but the pregnancy rate is not really higher. The miscarriage rate is definitely lower. Whereas when we use GnRH antagonist, we have two molecules. One is ganirelix and one is cetrorelix. They will act by receptor competition, so there's immediate decrease of gonadotrophin without any initial flare-up. And this action is dose dependent. The great benefit is this agent will reduce the duration of ovarian stimulation protocol, and it will also lower the requirement of gonadotrophin. So as you all are aware, the infertility is an expensive, time-bearing treatment. So if we can reduce the cost and reduce the duration of treatment, that is of great benefit. But as like agonist, it will reduce the incidence of ovarian hyperstimulation and multiple pregnancy further. But the great advantage here is, unlike GnRH agonist, there won't be any estrogen withdrawal symptoms. Now, why do we need these agents, agonist and antagonist? Is to prevent premature LH surge. Normally what happens is when only one follicle develops, the ovulation takes place something like around day 12 to day 16. But when you are giving gonadotrophin, there are many follicles developing, the estrogen level goes high up, and that higher estrogen will cause premature LH surge, and that will lead to arrest of oocyte and thereby cycle cancellation. So if you are doing an IUI cycle, you see there is no ovulation, you cannot do IUI. If you are doing IVF, there is no eggs or very, like poor quality eggs you collect. Now let's start with its advantage in IUI, because the area I come from, majority of the clinicians are actually doing IUI and very few of them are doing IVF. Now it is very interesting that when we talk about these agents, many of my clinician friends, they said, no, this is just for IVF. So I wanted to emphasize on the role of antagonist in IUI. It has been shown that in IUI cycle, nearly a quarter, 25 to 30%, they will have premature surge, and that will result in cycle cancellation. If you give them GnRH agonist, then almost completely it will abolish premature luteinization, but it wouldn't improve the pregnancy rate. And there remains a higher risk of multiple pregnancy and ovarian hyperstimulation. What we need to understand that this premature luteinization perhaps is not the cause, but one of the results of poor quality of the growing follicle. So if you look at a standard ovulation induction with gonadotrophin, be it HMG or FSH, you will see that normally we start stimulation on day 3 to day 7, and then we do an ultrasonography scan. So after 4 or 5 days of stimulation, we start GnRH antagonist. You can do it in a fixed protocol, or you can do it in a flexible protocol when the follicle is 12 to 14 millimeter and the estradiol level has reached a certain range. And the great advantage is there is no extra need of gonadotrophin, and there is less frequent scanning. So we scan our patients only 3 times, once at the beginning of the cycle, once before starting antagonist, and then finally to decide the time of IUI. And then after HCG, we do IUI and give progesterone for the luteal support. Now, if you go for IVF, you have already heard from Professor Pratap Kumar's talk that we have long protocol where we have to start, like day 21 of the cycle. So you need to take a very long time injection. Patients are very unhappy about it, particularly outstation patients. They don't like it staying in the city for a long time. We can have IVF long protocol starting from day 1. We can have short protocol where the GnRH is started from day 1 or day 2 of the menstrual cycle, or we can have ultra short protocol where the GnRH is going to give the initial flare effect I mentioned, initial stimulation, so that the follicles develop nicely. But with GnRH antagonist, the cycle is much more simple. You give, I say this rule of 5, or you can say 4 plus 6, 5 plus 5, or 4 plus 6. You give HMG or FSH, whether you're doing it for IVF or IUI, for 4 to 5 days of stimulation, then start GnRH analog again for 5 days along with the gonadotrophin. Most of the time the follicles are ready, otherwise you continue the stimulation a little longer. If the patient is responding too quickly, then give lesser amount of stimulation. So for me, this antagonist has made the ovulation monitoring and ovulation protocol very simple even for the beginners. If we compare GnRH agonist and antagonist, I've talked about this already. There is no flare-up effect with antagonist. It's a very simple method. It will easily reschedule IUI. We can avoid the weekends. It will decrease the risk of ovarian hyperstimulation, and it wouldn't have the side effects of GnRH agonist like estrogen deficiency symptoms, and also ovarian cyst formation, which are seen with agonist, won't happen. And we can use this in a normal cycle. So it has given us much more flexibility, and the treatment is not actually very long. Now, we need to look at some of the evidence. This is a study which looked at the luteal phase of the patients who were stimulated by gonadotrophin with or without antagonist. And it was shown that the estrogen, I'm not talking about IVF, I'm talking about IUI cycles. And when we give agonist or antagonist, we think the ovary is not going to function very well. There will be hypoestrogenic state. So you need to give luteal support, progesterone or HCG luteal support. It's essential. But in this particular study, it was shown that estradiol values in the follicular phase of the IUI cycle are not really too high to induce relative progesterone deficiency in the luteal phase. And the authors concluded the luteal phase support is not crucial with GnRH antagonist, although many a time we actually use progesterone luteal support. The another study looked at the success, and it was a randomized study. In one group, they used just FSH, other group they use FSH and GnRH antagonist, and it was found that the pregnancy rate was significantly higher in group receiving GnRH antagonist along with FSH. So in a control ovarian stimulation protocol for IUI cycle, we need to have GnRH agonist to improve the success rate. Right. Now, another study looked at the IUI timing, and it was concluded that the higher pregnancy rate was found and IUI timing was better scheduled by adding GnRH antagonist. And this is a very interesting study which showed that the incidence of multiple pregnancy was much lower if we were using GnRH antagonist in IUI cycles. And another study showed that premature LH surge was reduced and the pregnancy rate was much higher. And finally, this very interesting study, which helps us to avoid working over the weekend. I'm sure all of you will agree with me, it's very difficult to get your member of staff to come and work on Sunday. Now, this particular study showed that if you have a patient on Friday where the follicles are ready for ovulation, and then you have to come and do an IUI on Sunday, if you give them GnRH antagonist for 2 days, say Friday and Saturday, then you can delay the intrauterine insemination till Monday, and it wouldn't affect your results. Now, in summary, the advantages of GnRH antagonist in IUI cycle: A, it improves the pregnancy rate; B, it fits in with the normal timing of menstrual cycle. You do not have to plan the cycle. Third, it gives a shorter duration and lesser need for FSH therapy. So it's economical, it's much more patient friendly. 4, it overcomes the hassles of IUI over the weekend. And finally, it will have less side effects of GnRH agonist, which we were using before, like no ovarian cyst formation, no hormonal withdrawal symptoms like hot flushes, sweats. It will prevent higher order of multiple pregnancy, and it will lower the incidence of OHSS. Now, if we look at the findings with IVF cycles, then findings are slightly different. So what we have found that in this systemic analysis, where they compared the benefits of GnRH agonist and antagonist. GnRH antagonist came into the market available from the year 2000. So initial studies showed that the results with GnRH antagonist was actually poor. GnRH agonists were better. The first meta-analysis published by Al-Inani in the year 2001 or 2 actually showed the lower pregnancy rate. But when they reanalyzed the paper, it was found that most of the consultants, IVF is such a situation where you have to give the results. So all the consultants, all the specialists who have been brought up with agonist, they were hesitant to change their regime. So they were using antagonist only for poor responders or those who have several failed attempts or for elderly patients. So the results were biased. When they reanalyzed, the most 2 recent meta-analysis, Cochrane database analysis, showed that actually the benefit is different from IUI. The duration of FSH treatment will again be less with antagonists. So we have to use less duration of FSH and less doses of FSH. We will also see the hospital admission due to ovarian hyperstimulation will be much, much lower. The incidence is almost 50% less. But the pregnancy rate will be same with GnRH agonist and antagonist. So unlike IUI, antagonist is not actually improving the pregnancy outcome, the success rate, but it is definitely making it more patient-friendly, user-friendly by reducing the dose and duration of FSH and also making it safe by giving less OHSS and less incidence of multiple pregnancy. So GnRH antagonist has a special role in our practice, particularly in these patients, polycystic ovarian syndrome, which is very common nowadays, and these patients have a higher incidence of premature LH surge. It's interesting that elderly patients, particularly those over the age of 35, and also poor responders like low antral follicular count and low AMH will also respond better if you use antagonist rather than agonist. Now, those patients who responded very poorly, for them as well, we find that the response with antagonist is much better. So nowadays, endometriosis is the main condition where agonist is used for a long duration, but rest, we are very happy with antagonist. And if there was a previous cancellation due to premature LH surge, then antagonist is the drug of choice. So ladies and gentlemen, I would like to summarize by saying GnRH antagonist makes ovulation induction very short and convenient. There will be lesser treatment days, and as I have been repeatedly saying, lesser number of injections, because no one would like to take like 2 weeks of injection before starting the gonadotropin, then another 10 days. So ultimately they end up having 25 days of injection, where you use antagonist is only about 10 or 12 days. Serum LH suppression is very good as GnRH agonist protocol, and its suppression is instantaneous. It is very effective in PCO patient having high LH and high androgen level. As I said, it is also effective in elderly, in patients with poor ovarian reserve, and patients who are poor responders. I repeat, there is much lower risk of ovarian hyperstimulation syndrome, a condition which has made ovulation induction a dangerous sort of treatment. Many of our colleagues in the intensive care unit are very scared when these patients, very healthy young patients, are admitted with serious medical issues. And finally, pregnancy rates in IUI is better when you use antagonist in comparison to not using anything, but in pregnancy rate with IVF is comparable to GnRH agonist protocol. It's not better or it's not worse. So I would like to leave you with this summary slide where I tell my juniors all the time, ovulation induction is very simple. It is in your control. Just think about your hand, five fingers. So to make it very simple for IUI patient, I'm not saying for IVF all the time, that you give gonadotropin for 5 days, do a scan at the baseline. If it is suitable, baseline endometrium is thin, no residual ovarian cyst from the previous cycle, you start stimulation. For IUI, 75 international unit, be it FSH or HMG. For IVF, you can use 150 or 225. Bring your patient after 5 days. Then if your findings are favorable, if the dominant follicle has been achieved, then you continue the gonadotropin at the same dose and also give antagonist for another 5 days. If the response is too good, then you give for another 3 days. If the response is not so good, you need to increase the dose of gonadotropin. And if the follicle is already 10 millimeter, less than 10 millimeter, maybe a day or two later, you start antagonist. But in majority of the patient, antagonist has made our life very simple, avoid working over the weekends. So ladies and gentlemen, I would like to thank you for your kind attention, and I want all of you to have patients like this very happy with a single baby, which is the aim of our treatment, and not like having multiple pregnancy or ending up in intensive care unit with ovarian hyperstimulation syndrome. Thank you.